Hi, everyone. Thanks for joining. Susan, I
Hey,
think.
good afternoon, everybody. So sorry I was having technical difficulties. Good afternoon, everyone, and happy National Hepatitis Testing Day. My name is Susan Ingber. I work on the policy team in CDC's Division of Viral Hepatitis, and I will be your MC and Q&A moderator for today's webinar. Before we begin, I'd like to thank NASTAD's hepatitis team and today's speakers for their important work in this field and for sharing their experiences with us. Throughout the presentation, feel free to submit any questions you have for our speakers in the chat box, and I will read them off during the Q&A session at the end of the webinar. Finally, this webinar is being recorded. Here to welcome everyone and give us a preview of what's to come is Dr. Carolyn Wester. Dr. Wester is the director of the Division of Viral Hepatitis within CDC's National Center for HIV, Hepatitis, STD, and TB Prevention. In this role, she oversees the design and implementation of national programs for viral hepatitis prevention, control, surveillance, and outbreak response. Dr. Wester.
Great, thank you very much, Susan. And again, happy National Hepatitis Testing Day to everyone. Thank you for attending today's Hepatitis Awareness Month webinar. CDC appreciates the support from NASTAD in developing and hosting this event. Viral hepatitis remains a significant public health issue, as you'll be reminded momentarily when we present findings from the latest surveillance report and National Viral Hepatitis Progress Report. To end the trends in viral hepatitis epidemiology, CDC released its strategic plan for advancing viral hepatitis elimination efforts through 2025 last fall. Our strategies, which align with the National Viral Hepatitis Strategic Plan, focus on integrating care for earlier detection and treatment, expanding surveillance to improve case detection and inform public health action, and reducing viral hepatitis-related disparities. Many of you are championing similar efforts in your jurisdictions, and we thank you. CDC is also looking forward to kicking off the new Integrated Viral Hepatitis Surveillance and Prevention for Health Departments Cooperative Agreement tomorrow during a call with the new recipients. CDC, NASTAD, and others are lined up to provide technical assistance and support to the new recipients as they implement their viral hepatitis surveillance and prevention activities. Unfortunately, as we know, COVID-19 has presented many challenges for viral hepatitis prevention and treatment programs and services. NASTAD and National Viral Hepatitis Roundtable will share details about the impacts on syringe service programs, health centers, and health departments. Many programs, however, have not only met the challenge, but leveraged opportunities presented by the pandemic response to advance their own viral hepatitis work. In the last segment of this webinar, we will hear from some of these programs as they share their successes and lessons learned. I look forward to the discussions that follow during the Q&A session. Thank you.
Thank you, Dr. Wester. And next, we will be hearing from CDC's Dr. Neil Gupta. Dr. Neil Gupta is the branch chief for the Epi and Surveillance branch at CDC's Division of Viral Hepatitis. Dr. Neil Gupta, the floor is yours.
Hi, everyone. Good afternoon and good morning. I have the slightly impossible task of trying to summarize the 2019 surveillance report and national progress report to you in 10 to 12 minutes. So what I thought I would do was just give you the highlights of the report. These data will be released today, and some of the other features like the PDF and the national progress report will be released in the weeks to come. Will forgive me in advance for moving through these slides quickly, but I just wanted to give you a summary of what you might find online. Next slide, please. So just some new additions to the 2019 report. We'll be providing more characteristics on chronic hepatitis B and C. So in addition to the number and rate of newly reported cases, you'll find more information on age, sex, race, ethnicity, and urbanicity, as well as state and HHS region. We've included information on urbanicity, and this was actually based on a classification scheme by the National Center of Health Statistics for urban and rural classifications. And for the first time, we'll be including data from our perinatal hepatitis B prevention program. Some of you may know that we have our colleagues in the Immunization Services Division have a robust program for perinatal hepatitis B prevention. And so we presented data from the 2018 birth cohort that looks at surveillance of prevention measures as well as outcomes in this cohort. On the right here, you see a summary of acute disease in 2019. And in interest of time, I'll just go over these in the subsequent slides. Next slide, please. So let's start with hepatitis A. Next slide, please. So on the, I'll go, back to the summary slide for one slide. Yeah, so hepatitis A, this is the overall new cases reported in 2019. Over 18,000 cases reported, which when you adjust for under ascertainment and under reporting using a model that we've published previously, there are about 37,000 estimated infections of hepatitis A in 2019. On the left is an at-a-glance sort of snapshot of what the year looked like. These highlight groups that were disproportionately affected or had higher rates than the national rate of hepatitis A. And on the right, you can see what we've experienced in 2019 was a substantial increase, over 1.5 times the number reported in 2018. And when you compare to 2015, this is over 13 times the number of cases that we experienced in 2019. And many of you know that this is because of the ongoing person-to-person outbreaks that in 2019 were reported in over 30 states. So a substantial increase in the burden of disease. Next slide. So as you can see on the map on the left, these are the states that were most heavily impacted. You can see there was a large high rates in the Appalachian region as well as other states around the country, including Florida and New Hampshire. When looking at risk factors, which is provided in the bottom left table, injection drug use was the most commonly reported risk factor. I will say, however, that there are a lot of other risk factors, as you all know, for hepatitis A that our surveillance system, unfortunately, right now does not do a good job of collecting, and that will be improved once our new case report form is live. But for example, non-injection drug use is commonly reported in these outbreaks and is not adequately captured in our surveillance system. So in a quick summary, as you know, a substantial increase in hepatitis A burden in 2019 due to these outbreaks that are occurring primarily among people experiencing homelessness and people who use drugs. Among those cases that were reported, most occurred among persons aged 20 to 49 years old, non-Hispanic white persons, and in urban areas. And you can see here the highest incidence rates were in the Appalachian region. Next slide, please. So we only have one national progress report goal for hepatitis A, and you can see that our goal to reduce estimated new hepatitis A infections by greater than 40%, we are far off of that goal. Again, this is due to the widespread person-to-person outbreaks. I do think we can get on top of this. In fact, our 2020 provisional numbers look much better. And I think if we can implement the public health interventions that we know we are able to do and get vaccine out to the populations that need them, that we will be able to meet our goal. Next slide, please. So again, sorry for moving quickly, but we'll move to hepatitis B. As you can see, in 2019, more than 3,000 cases of acute hepatitis B were reported, which after adjusting is estimated to be about over 20,000 estimated infections in 2019. Again, on the left, you can see those groups most affected. When you look at the graph on the right, it really shows what we have seen over the last several years, that the incidence has been relatively stable, which is good that we're not seeing increases, but of course bad that we're not able to reduce incidence for vaccine preventable disease. In 2019, the rates were highest among those who were aged 40 to 49 years. Next slide, please. So this map on the left does look similar to what we saw for hepatitis A in terms of states that were disproportionately affected. You see a lot of disease in the Appalachian region as well as other states throughout the country. On the top right, these are figures that you're used to seeing year to year. This is the rates of reported acute hepatitis B by age group. And you can see here that the age groups of 30 to 49 years experience the highest rates. And we will start to see this reflect the epidemiology of the vaccine being introduced and widely adopted in the early 90s. Those groups protected by hepatitis B vaccine in childhood will have lower rates over time. And then if you look at on the bottom right, this is rates of acute B by race ethnicity. And you can see, again, that rates in non-Hispanic white persons and non-Hispanic Black persons were highest in 2019. Next slide, please. What we've done here is show you that some of the data that we presented is sort of new for this report is demographic characteristics of newly reported chronic hepatitis B on the left, which is in green. I want to highlight that this is not prevalence. This is newly identified chronic hepatitis B in the surveillance year of 2019. And on the right, you see rates of death with hepatitis B listed as the cause of death in purple. What you see for chronic hepatitis B disease, that rates were highest in those 30 to 39 years, followed by those 40 to 49 years. And unlike acute disease for hepatitis B, chronic disease, there's a disproportionately higher rate in Asian Pacific Islander persons with a rate of 18.9 per 100,000 population. Looking at deaths on the right, as expected, you see higher death rates in older populations. The highest rate for hepatitis B associated deaths was in a 65 to 74-year-old age group. And again, as might be expected for deaths, just based on what we know about the prevalence of disease, as well, and as illustrated by the number of newly identified chronic hepatitis B infections. In 2019, the highest rate of deaths was in Asian Pacific Islander persons at a rate of 2.1. Next slide, please. So again, just to summarize very quickly, the incidence of acute hepatitis B in 2019 has about been the same. Injection drug use was the most commonly reported risk behavior or exposure. Among acute cases reported, most occurred among persons aged 30 to 59 years, non-Hispanic white persons, and in urban areas. And for chronic, newly identified chronic hepatitis B and hepatitis B associated deaths, rates were disproportionately higher in Asian Pacific Islander persons. Next slide. So we have 4 goals for our national progress report for hepatitis B. For the first time, we've met our goal of reducing new infections by greater than 20%. But again, we're just at that goal, and so I think we can do a lot better. You know, at least this is encouraging news for this year. So for all 4 of our goals, reducing new infections among people who inject drugs, reducing deaths by 20%, and reducing deaths among Pacific Islanders, Asian Pacific Islander persons, we have met all of our goals. Next slide, please. So here is acute hepatitis C. As you can see, new cases reported was over 4,000 with over 57,000 estimated infections in 2019. If you look at the number of acute hepatitis C cases reported every year, again, that's a concerning increase every year of acute hepatitis C infections. With the most recent year, the rates were highest among persons aged 20 to 39 years, and injection drug use was the most commonly reported risk factor. Next slide, please. So again, on the map on the left, shows you some of the same states that had highest rates of hepatitis A and B are included here, but you will also see other states around the country reporting high rates of acute hepatitis C. The one comment I wanted to make here is that, like the other viral hepatitis, but maybe more so for hepatitis C, the capacity of the state to conduct surveillance and also varying laws or reporting policies in state does affect an ability for a jurisdiction to be able to identify and report acute hepatitis C. On the top right, you see the age groups most affected by acute C were age 20 to 39 years. And again, the race ethnicity group with the highest rate of acute hepatitis C was in American Indian Alaskan Native persons. I do want to point out that the numbers in the numerator and denominator here are small, so small changes can result in wider fluctuations from year to year. Next slide, please. So looking again at chronic hepatitis C cases on the left, these are newly reported in 2019 compared to rates of deaths of chronic hepatitis C on the right. The age group with the most highest rate of newly reported chronic C was age 30 to 39. And by race ethnicity, American Indian Alaskan Native persons had the highest rate of newly identified chronic C. In terms of hepatitis C associated deaths were highest in those aged 55 to 74 years. And also, as might be expected based on newly identified chronic disease as well as prevalence data, rates of death were highest in American Indian and Alaskan Native persons. Next slide, please. So in summary, we've had an increase in the number of reported acute hepatitis C in cases increased 70% from 2015 to 2019. Injection drug use was the most commonly reported risk factor. Among those acute cases reported in 2019, most occurred among persons aged 20 to 49 years, non-Hispanic white persons, and in urban areas. You can see here the states that had highest incidence rates of acute hepatitis C. And for chronic hepatitis C and hepatitis C associated deaths, the rates were highest in American Indian and Alaskan Native persons. Next slide, please. So we have 5 goals in our National Progress Report for hepatitis C. You can see we are not meeting our goals. Unfortunately, we're going in the wrong direction for reducing new infections overall and reducing new infections among PWID. Next slide. But we do see some encouraging news with the availability of highly effective DAAs. We have met our goal for reducing overall deaths by 20%, reducing deaths among AI/AN persons by greater than 30%, and reducing deaths among Black persons, non-Hispanic Black persons by greater than 30%. Next slide, please. So I think I covered most of this, but a large increase in hepatitis A has been associated with outbreaks among people who use drugs and people experiencing homelessness. We've only made minimal progress in reducing the incidence of hepatitis B, and the epi varies considerably by demographic characteristics. Despite seeing some encouraging declines in hepatitis C-related mortality, we're still continuing to see new cases increase, and injection drug use continues to be the most predominant risk factor. I think, and I hope that inclusion of these data for chronic hepatitis B and C and urbanicity and can help us better understand the epidemiology and identify targeted areas for prevention. We continue to prioritize this and provide more data for public health action in our surveillance report. And I think this really highlights an important opportunity to leverage the lessons that we've learned from COVID-19 to improve vaccination testing and linkage to care for medically underserved populations. I know that's what the focus of today's webinar is about. I think it's really important, and you all are the experts who work every single day in providing services to these populations. And the more we can do to think more comprehensively about providing services rather than be disease focused, I think will serve our populations better in the long run. Next slide. So you'll see this when our National Progress Report is released. This is just a quick summary of all of our goals and where we are. And you can see we're unfortunately not meeting our goals for new hepatitis A infections or reducing new hepatitis C infections overall and among people who inject drugs. Next slide. So I want to thank a number of people who've supported this work. And I just want to say to all of you, it's really important for us to provide meaningful data for you. So any feedback you have for us, we're open. We would love to hear positive or constructive ways that we can provide data that actually helps you to use this and inform your public health interventions. And with that, I'll turn it back over to you. Thank you.
Thank you for the preview of CDC's Viral Hepatitis Surveillance Report and National Progress Report, Dr. Gupta. Next, we'll learn more about COVID-19's impact on viral hepatitis prevention and control activities from Lauren Canary and Gautama and Thierry Reed. Lauren Canary is the advisor and former director of the National Viral Hepatitis Roundtable. In 2020, Lauren Canary completed a fellowship with the National Rural Health Association and is currently serving a 2-year elected term on its Rural Health Congress. Lauren is also pursuing a medical degree at the Virginia Tech Carilion School of Medicine in Roanoke, Virginia, and serving on the board of directors of the Virginia Harm Reduction Coalition. Ms. Thierry Reed is director of NASTAD's hepatitis team and leads NASTAD's programmatic and technical assistance initiatives related to viral hepatitis. Prior to NASTAD, Gautama served as chief of the Center for Viral Hepatitis at the Maryland Department of Health, coordinating departmental and statewide efforts to prevent, control, and treat viral hepatitis. Thank you both.
Thank you so much for inviting me to be on today. It's really a pleasure to be on and to raise awareness around viral hepatitis and COVID-19, in what has been a wild year. So I wanted to go ahead and dive into some survey findings that we had put together last year. So I'll be quick. I know we're short on time today, so if you can move to the next slide, that'd be great. Great. So overall, while I was director of the National Viral Hepatitis Roundtable, I came together with some of my colleagues who are on the line today, who I greatly appreciate, to put together a survey. We really wanted to act quickly to understand what was happening in our communities, both the people that are impacted personally by viral hepatitis, but also the many folks involved in service provision. So we put together a survey and launched it last summer from June through August. So we sort of got a snapshot of how COVID-19 was impacting various sectors of viral hepatitis support and response. So we mainly wanted to target 4 groups, being people impacted by viral hepatitis, our public health staff, community-based organizations and our clinical providers. Next slide. So overall, we really wanted to get just our finger on the pulse. What was happening? What was going on in terms of testing and treatment? What was needed? We hoped that if we could illustrate some of the barriers to viral hepatitis care, that we might better be able to advocate for our communities and to identify resources that could be helpful. And also to document the impact of COVID on our community, which I think is important, as we're looking back now at, where do we go from here? And next step. So I wanted to just go through some of the key findings, and HepView has been great about communicating these in sort of a visually exciting way. So I apologize that this is just sort of text on your page, but wanted to highlight some findings here, especially from our personally impacted community members. Overall, we sampled our Hep B and Hep C community members. We had a bit of a better response from those living with hepatitis B than those living with hepatitis C, although we did have some folks who've been cured of their hepatitis C responded. 15% of those were living with liver damage or were post-transplant, and thus were at greater risk of kind of implications of COVID-19 as they were becoming available to us, as this knowledge was becoming available. We found that the number one source of information for our patient community was national news outlets, followed by health departments, which is helpful to know in sort of informing efforts. Unfortunately, we found that a third experienced challenges in accessing healthy food as a result of the pandemic. So something to be aware of moving forward in the ways that our communities are impacted. We also saw that 40% experienced some kind of unemployment in their household due to COVID-19. And 15% of those who sought care were unable to get all the services they needed. So on one hand, we're really thrilled to see that 85% were able to get the services that they wanted, but knowing that 15% were unable to, especially given the vulnerability of some of our patient populations, we wanted to take note of. Next slide. We can advance to next. There we go. And I just wanted to show here some of the different ways people are getting information. Again, this sort of was new to us. We weren't sure where folks were going, and national news combined with health departments, both state, local, and CDC were really crucial. So I think this may help us sort of bolster our messaging going forward when we have urgent needs to get to our community, to think about how we're engaging with national media, but of course our health departments and messaging directly to those impacted. Next slide. For clinical providers, we were seeing a greater number of responses from those in urban settings who are primary care providers. 78% used telehealth to provide services, and unfortunately about half of those face really significant challenges in adopting telehealth for their viral hepatitis services, issues with technology, supplies, uptake, et cetera. About just over 90% of those experiences challenges to viral hepatitis care, which of course is notable. Deprioritization, of course, COVID-19 was front and center for so many folks last year. We had interruption in things like blood work, staffing shortages, PPE was not necessarily prioritized for those doing viral hepatitis testing. And then trying to provide things at home ended up being a challenge for a lot of folks where, patients didn't want to leave home and risk coming to a clinic, would have preferred to have blood draws done at home, for example, but that logistically and billing wise was a challenge. Next slide. What I thought was really incredible, and I want to give a huge shout out to our clinical providers, is that the majority of them continued a lot of the viral hepatitis services amid COVID. We saw some downturn in sort of the amount of testing being done, or providers that could do testing and vaccination, counseling and treatment. But overall, a lot of clinics were able to maintain those services. So huge props to our clinical providers in kind of muscling through and making that happen. Next slide. From our community-based organizations, we had, unfortunately, about 2/3 were unable to get support for modifying their services. Nearly all of the CBOs had to adapt their services in some way, but mostly did not receive support, unfortunately. And of those who did receive support, about a quarter received funding from their health department to do that. And so I think just something notable for us to be considering how we're supporting our CBOs in future efforts. Over half had to lay off or furlough staff, unfortunately. A quarter did not have sufficient PPE. And some of the support asks that they had that would be helpful were, of course, funding, TA and guidance for providing viral hepatitis services at the pandemic, and then, of course, supplies. So again, I think thinking about the fact that CBOs were oftentimes left out of some of our funding or support from public health agencies is really notable. And then thinking about sort of our TA and guidance, especially as our CBOs are serving various communities that may be vulnerable, we may want to consider how our guidance should adapt to some of those communities. Next slide. One thing that I thought was sort of devastating here with our CBOs is that there was a significant reduction in services last year. And of course, our CBOs are central in reaching our populations, especially those most vulnerable populations. And we really saw a downturn in testing and vaccination. So I think that'll be notable as we look forward to the impact on our community, is that there was a lot less testing in our community-based efforts. Next slide. And then we had health department staff. So the majority of responses were from state health departments. We had additional from county and city health departments. The majority of those reported that they had redirection of viral hepatitis staff to COVID-19 efforts. Less than 20% of health departments provided information about the intersection of COVID-19 and viral hepatitis. And again, this survey was done last summer, so that's not to say that they didn't develop or put things out later, but it seemed like that was sort of not a priority area for many health departments, looking at sort of intersectionality of diseases, which is fair. More than 60% of their hepatitis activities were substantially impacted. Some were halted in 10% of the cases. And they noticed that TA and guidance would be great, funding PPE as well. Next slide. They had to cut back significantly on community outreach and prevention activities. You can see here, these were all the ones that had been impacted. So just again, noting this year that a lot of our activities last year were impacted, will be significant elimination activities. Next slide. And here is a image by HepView. They put together sort of summarizing some of the key findings. So again, I'm sorry for flying through everything today, but if you want some more details, I think if you go to HepView's website, you can see this figure. I did want to note the populations disparately impacted by COVID-19 as identified by health departments in this survey. Next slide. And to make the point that our community-based organizations are serving these same populations as reported in the survey. So when we're thinking about how to reach vulnerable communities, we have to ensure that we're supporting CBOs. Next slide. So where do we go from here? My big takeaways were that, our CBOs and health departments may need additional support now to recover from last year. That our surveillance data is definitely going to underestimate true cases because our testing was impacted. We're going to have to double down on outreach, testing, vaccination, and our messaging to catch up from last year's losses in our public health outreach. In future messaging, we really need to consider direct funding to CBOs and developing hepatitis-specific guidance for them. With health equity, again, we've got to consider supporting those CBOs. And I think as a community, we'll have to consider how we're going to measure and address burnout among all parties involved, in particular public health staff, who we know were tasked with extraordinary efforts last year. Our CBO staff, many of whom were laid off. There's a lot of stress that's happened in our community this year, and thinking about how we're going to address that, I think, is important. Next slide. Finally, here's my information. Feel free to reach out to me if you have any questions. Again, sorry for flying through this, and I appreciate the chance to be here.
Perfect. Good afternoon, everyone. I'm so excited to have a chance to talk to everyone, and that we have all come together with so many participants for Hepatitis Testing Day, and that we're having such an important conversation. So similar to the speakers before me, I will be going through the information that I shared today very quickly. So I sincerely apologize if you miss anything, but we are recording this webinar, and we do have slides available following the webinar. So I'll start off by just saying that NASTAD is a leading nonpartisan nonprofit association that represents public health officials who administer HIV and hepatitis programs in the US. And our membership includes public health officials in all 50 states, the District of Columbia, local jurisdictions, Puerto Rico, the US Virgin Islands, and the US Pacific Islands. So wanted to note that because it's really critical to understand why it was that we decided to go about learning more about the impact of the COVID-19 pandemic on specifically viral hepatitis and HIV health department programs. Next slide, please. Thank you. So with the onset of the COVID-19 pandemic, something that became immediately clear is that health department viral hepatitis leadership and staff would be and continue to be central to the nation's public health response. Among the nation's leaders in infectious disease, their expertise in outbreak response, disease control, and vaccination has proven to be critical to the federal, state, and local responses to the ongoing pandemic. So in April of 2020, we at NASTAD set out to better understand and document the impact of COVID-19 response, and in particular, on health department hepatitis and HIV programs, and to be able to assess the needs of their staff during the ongoing pandemic. Next slide, please. So what we did was put together a brief request for information. We disseminated the request for information to our membership, including viral hepatitis, Ryan White HIV/AIDS program staff, as well as their Part B staff, AIDS drug assistance program members, or program staff, and HIV prevention staff. The 3 requests for information, or RFIs, were disseminated in 3 parts across 3 separate timeframes. So first, Part 1, the RFI Part 1, was disseminated in April of 2020 with 56 responses received. A second RFI was disseminated in July 2020 with 35 responses received. And a third RFI was disseminated in March of 2021 with 64 responses received. Next slide, please. In summary, what we learned from health department viral hepatitis programs in particular was, when asked, what do you anticipate the biggest impacts of COVID-19 will be on your hepatitis programming? So remembering that this was disseminated in April 2020, very early on in the pandemic. We learned that 93% of viral hepatitis respondents stated that they anticipated a reduction in outreach, education, testing, and linkage services. As respondents shared, it was anticipated this would disrupt the traction and momentum many programs had gained in recent years, especially in their work with harm reduction and other high-impact settings. Additionally, 80% of respondents anticipated detailing of health department viral hepatitis staff to COVID-19 response. When asked in detail about program changes of particular concern, we heard that 1/3 of hepatitis respondents, we heard from 1/3 of hepatitis respondents that half or more of their staff had been detailed to COVID. As one jurisdiction described, even their student interns had been detailed. Next slide, please. Looking at the same question across all 3, when asked, what do you anticipate the biggest impacts of COVID-19 to be on your programs? Across all 3, respondents reported decreased viral hepatitis program services delivered by their health department program and decreased staff capacity due to detailing to the response. Further, one difference we noted from Part 1 to Parts 2 and 3 is that in Part 1, there was very limited participation in viral hepatitis program services, whereas in Part 2 and 3, the biggest impact became other, and specifically that there were limited services being provided by their CBO partners and clinical partners. Next slide. Across all 3 RFIs, health department viral hepatitis staff detailing remained significant and constant. Next slide. Thank you. So what are the key takeaways? First, the biggest impacts of the ongoing pandemic on viral hepatitis programs have been on staffing, program participation, and the availability of services within health departments and in the community. Over a year later, health department viral hepatitis programs continue to face limited staff capacity due to the ongoing response. And one of the most significant takeaways and considerations is that short and long-term recovery strategies are definitely going to be needed in order to sustain and expand these essential viral hepatitis services that are conducted by health departments and their partners. With that, I'd like to say a sincere thanks and express appreciation to our hepatitis prevention and surveillance colleagues at health departments throughout our nation for their tireless work to respond to the COVID-19 pandemic and sustain viral hepatitis services. Additionally, I want to thank Emily McCloskey and Amy Killalay of NASTAD for their leadership in the development of the RFIs. Thank NASTAD's hepatitis team, Rita Isabel Lechuga, Alex Eanes, and Jasmine West for their support, and thank CDC for the opportunity to partner on this important webinar today. Thank you.
Thank you, Ms. Canarian and Thierry Reed. Now we will learn how 3 jurisdictions have successfully responded to the pandemic challenges we just heard about and implemented novel approaches that can be leveraged after the pandemic ends. First, we'll hear from Lindsay Sizemore about Tennessee's Ending a Syndemic program. In 2015, Ms. Sizemore started as the sole viral hepatitis program employee. Today, under her leadership and technical advisement as the Viral Hepatitis Program Director, the Viral Hepatitis Program consists of over 30 employees statewide that conduct surveillance and offer prevention, linkage to treatment, linkage to harm reduction resources, and clinical support every day. Welcome, Ms. Sizemore.
Great, thank you so much. Can you hear me?
Yes.
Great, awesome. So again, thank you for that introduction. Hi, everyone. Today I'm going to talk very briefly about our integrated strategic planning process called End a Syndemic Tennessee, and how we have addressed the challenge of doing a community planning process during the COVID-19 pandemic. Next slide. So End a Syndemic Tennessee was inspired by both the Ending the HIV epidemic planning across the country, as well as federal HIV and hepatitis C vulnerability assessment. We know many of our communities that were heavily impacted by the HIV epidemic are also disproportionately impacted by the viral hepatitis epidemics, as well as sexually transmitted infections and substance use. So we wanted a framework that would speak to the interconnected challenges our communities were facing. Next slide. That's when we found syndemic theory. So what is a syndemic? A syndemic is a set of overlapping epidemics that are interconnected and fuel each other, leading to worse health outcomes for individuals and for communities. Next slide. Health conditions included in a syndemic are connected through data, biology, shared behavior, and through larger structural and social forces, which we can think of as social determinants of health. These connections tie the included epidemics together, making it nearly impossible to address one epidemic successfully without addressing the others. Next slide. When we considered the qualifications defining a syndemic and the data in Tennessee, we decided to include HIV, viral hepatitis, sexually transmitted infections, and substance use disorder. Our logo is a tribute to both our state and the included health conditions. The ropes are the awareness colors of the separate epidemics and are bound together. And in the center are the 3 stars, which are symbolic of Tennessee. Next slide. And next slide. We knew we couldn't ask community to collaborate and communicate across programmatic areas if we were not able to do so ourselves. And so we know we had to start with the person in the mirror, so to speak, and break down the silos internally first. So we pulled together leadership across various programs at the Tennessee Department of Health and the Tennessee Department of Mental Health and Substance Abuse Services that have programs related to the prevention and treatment of HIV, sexually transmitted infections, substance use disorder, and viral hepatitis. This includes directors and staff from the programs bulleted on this slide. Next slide. We knew that any planning process that doesn't engage local leaders will miss the mark. And we also knew that what is going on in East Tennessee with the conditions in the syndemic is vastly different than what is happening in West Tennessee. So we divided the state into 7 regions that align with what we know about each of the conditions and resource distribution in the state. We then recruited local experts from each region to serve as tri-chairs. These champions come from a diverse array of life and work experiences, including folks living with one or more of the health conditions in the syndemic, community-based organization employees, healthcare providers, local health department staff, and more. To increase communication and collaboration between these local leaders and State Department staff, we also have 2 or more representatives serving as State Department representatives for each region. Together, these local leaders and State Department representatives make up the regional core leadership teams. These teams review materials to be presented to community, recruit folks to the planning process, serve as subject matter experts, help facilitate conversations during meetings, and will be the first folks to review draft versions of our plan. Next slide. So since March of 2020, we have been recruiting community partners to participate in regional planning meetings where strategies for the final plan will be identified. We currently have over 320 people currently registered statewide from a variety of organizations and lived experience across the syndemic conditions. Next slide. And next slide. Originally, the planning process was intended to be conducted in person across the state, but due to the pandemic and the need to socially distance, we pivoted to a virtual planning process. We use WebEx as our video conference platform, which has video and audio sharing capabilities, breakout rooms, chat functionality, and more. To make meetings more interactive and to allow for anonymous feedback, we also use Mentimeter. On this platform, participants can rank ideas, respond to questions, provide anonymous feedback or ideas, and react to content. It's very easy to join and navigate from a phone or a web browser. And since we started this process, we've had more than 30 virtual planning meetings conducted across the state. Next slide. We also designed and launched a website that will act as a public hub of resources for Syndemic Tennessee. If you scan the QR code on the left side of the screen, it will take you to our website, or you can type in the link at the bottom of the slide. On our website, you can learn more about ETS, including an overview of our project and project goals, a calendar of events, meeting notes. You can leave feedback. You can register for the planning process, get linked to resources, and more. Next slide. Community involved in the planning process also wanted a way to network and communicate with each other outside of the limited time during our formal planning meetings. After searching through various online engagement platforms, we decided to go with Basecamp because of the number of different features it has and the ease of use. Participants involved in Syndemic Tennessee can request to be added to this private platform. Once added, they will have access to the headquarters board, where we have statewide announcements, resources, and opportunities, and they will also be added to their appropriate regional board. Unlike the website, Basecamp is closed to include only those involved in the planning process and who fully collaborate, meaning all the folks on the Basecamp can post announcements, events, and resources. Next slide. So our words have impact, and this became very clear at the beginning of the Syndemic Tennessee planning process as we convened stakeholders from across sectors, identities, and lived experience. Most people had good intentions, but sometimes their words didn't always reflect this, as language is tricky and ever evolving. So we wanted to create a tool that was user-friendly with guidance related to HIV, sexual health, substance use, viral hepatitis, and communities disproportionately impacted by the syndemic. Our intent with this guide was to help build a culture of understanding and compassion rather than one of stigma, shame, and stereotypes as we move through this planning process. Again, you can view the guide on our website, or you can scan the QR code shown here, and it will take you directly to the PDF. Next slide. We also deployed a demographic survey to collect data about those currently engaged in the planning process. This is to ensure the perspectives of those disproportionately impacted by syndemic conditions are included. Results from the survey will identify gaps in perspectives, which will inform future recruitment efforts, key informant interviews, focus groups, and survey development. Next slide. So thank you so much for your time today. I'll be joined by my colleague, Amber Coyne, for the Q&A. Amber has been spearheading the ETS efforts in Tennessee, along with Dr. Meredith Brantley and myself. And so also please feel free to reach out to us anytime at the email shown on the screen. Thank you.
Thank you for sharing your program's experience addressing the syndemic, Ms. Sizemore. Our next speaker is Raudel Bobadilla, a senior research coordinator and community health worker instructor who serves as the program manager for the UT Health San Antonio South Central AIDS Education and Training Center. Mr. Bobadilla has helped create innovative treatment pathways within 28 clinics across South Texas. Mr. Bobadilla also serves as the community health worker manager for an HIV/HCV co-infection project. He manages a team of community health workers throughout South Texas to improve patient navigation and ensure movement through the HCV and HIV care continuum. Welcome, Mr. Bobadilla.
Thank you so much for the introduction. So in the interest of time, I'm just going to be as brief as possible going through this. I'm going to be talking about some of our telementoring modalities that we've implemented in a couple of our programs, initially before the pandemic, but now have proven very useful during the pandemic as well. So next slide, please. So just an overview, again, current programs. I'm going to talk about our Stop HCV program, which utilizes our teleconsultation model, and then our Tackle HIV/HCV co-infection program, which uses the ECHO model. I'm also going to talk about some initiatives taken during the COVID-19 pandemic and some lessons learned and challenges that we come across as we've gone through our programs. Next slide, please. So first, I'm going to talk about our Stop HCV program. It is a CBERT-funded program that offers education to Texas clinicians, staff, and CHWs about HCV and HCC prevention. It's a multifaceted clinic-based program for HIV screening for our clinics to counsel, evaluate, and treat chronic hepatitis C. We have 4 clinic systems here throughout South Texas, which comprise of 28 clinics overall, all in rural settings. These components include modifying EMRs to flag patients needing hepatitis C screening. We developed an app and implemented a mobile app for newly diagnosed chronic chronically infected, and also really focused on CHWs as patient navigators as well. And we also cover testing for all uninsured individuals going through our program as well. So as long as they were baby boomers and had elevated PLTs, they were screened for hepatitis C. And if they come back chronically infected, we actually cover their full labs to be able to go through with treatment there in their medical home. So we use our teleconsultation office hours as a way to mentor providers to do this, who are primary care clinicians really treated and cured their uninsured patients with guidance from our specialists through these teleconsultation office hours there in their medical home. Next slide, please. So this is our teleconsultation model. We basically use this patient review form that our CHW puts together, and then the PCP and our hepatologist have a one-on-one call. It's usually done during their lunchtime, usually lasts 10 to 15 minutes tops. There they discuss everything needed to recommend treatment for that patient, and they're given recommendations about DAA therapy along with some teaching points along the way as well. And it's usually our CHW sit through this call, and then from there the primary care provider and the CHW could then move towards getting them onto medications through the PAP program. Next slide. These are some of our outcomes for the Stop HCV program. We screened over 32 patients for hepatitis C in 60 counties all throughout Texas. We've had over 1,600 confirmed chronic hepatitis C infection. Among those within our teleconsultation model, we've put around 228 patients. We've discussed 228 patients through our teleconsultation model. And this is very significant because I'm confident they would never been screened or even treated or cured for hepatitis C if it wasn't for this program here in South Texas, at least. So now I'm gonna switch over to the other program. If we could please advance the slide. And our other telementoring modality, which is the Tackle HIV/HCV program. Tackle stands for Targeted Access to Community Knowledge Linked to Treatment and Education for HIV, HCV, and People of Color. It's a really long title, but it was funded through HRSA. It includes 5 Ryan White funded clinics in South Texas. It has 4 main goals, but I'm gonna really focus on goal 2, which is provider support for HIV/HCV co-infection management and treatments. And we're doing management and treatment through the ECHO model. If you could please advance the slide. Thank you. So a lot of people are familiar with the ECHO model now. It's really having a moment this past few years. It's really about moving knowledge and not patients. So the anatomy is basically a brief didactic that's 10 to 15 minutes. And then we go into a case-based discussion where a provider presents a de-identified case to our specialty hub team. We usually provide CEs at all our educations. Really, ECHO is an all teach, all learn environment. Next slide. So really, as we're doing it today, we do this through Zoom. So all you need is a computer, a smartphone, and audio-visual capabilities as far as, and also Wi-Fi broadband internet to connect to our ECHO sessions. Next slide. And then we launched through this Tackle program in HIV/HCV ECHO, which focused on treating hepatitis C among people living with HIV. But then in fall of 2020, we converted it to an HIV echo with and still discussing co-infection cases as well. We offer wide-ranging didactics aimed at all members of the care team. It's ongoing. We have it every second Monday and fourth Friday of the month. It's really for anyone interested in learning more about HIV care or co-infection care as well. We offer CME and MOC, and then we have a very diverse hub subject matter experts at each of our sessions, at every session, which includes an infectious disease specialist, a hepatologist, a pharmacist in both an academic and community-based setting, a community health worker, and mental health expert as well, just so the provider that's presenting their case up to our hub team has a full array of mentorship as they're treating this patient in their own clinics. Next slide. So these are some of our didactics that we've presented. It's really far and wide, from hepatitis C to, we talk about addiction as well. Next slide. And even incorporated some COVID-19 specific didactics that it's brought up by our learning network that they want to learn about this as well. Next slide. So this is our ECHO. We have 46 sessions so far, had over almost 1,400 total number of attendees. We average around 24 attendees per session. We've reached over 3,500 people living with HIV and 146 co-infected patients through this ECHO. So we've had quite a bit of reach through this platform. Next slide. And I also just want to highlight CHWs as case managers. Without CHWs, these programs wouldn't be able to exist. So from initially track patients once diagnosed with chronic Hep C, to help patients understand the reasons for and ways to evaluate the disease stage through that mobile app, and then just education and talking to them. They ensure patient completes all the tests and follow-ups. They make sure that the patient has all the records ready for our telementoring process, either if they're going through our teleconsultation model or ECHO model. They also ensure that once that provider receives that recommendation from either the hepatologist or the hub specialty team, that the CHW follows up with them and makes sure that they apply for the PAPs to access those DAAs, as well as deal with any lifestyle changes needed or social issues needed that was brought up during our ECHO sessions. And our CHWs really sit through the ECHOs as well and provide their input, as well as in our teleconsultation calls as well. Next slide. So COVID-19, we were in a great position since we were doing virtual meetings to continue what we're doing, but it kind of stopped clinic-wise just because their focus changed to COVID-19, and setting up telemedicine and telehealth programs is what we initially started. So next slide. So to help aid with that, we launched a COVID-19 telemedicine implementation and technical assistance ECHO, just to help and assist them to transition over to telehealth, since these were a lot of rural FQHCs. They had some knowledge gaps that needed to be filled, so we helped with regulations and billing changes, practice considerations for a rapid launch, different modalities available, and then some considerations in those short and long term that they should consider for this. And we had the UT Virtual Health Network help with this, as well as the local AHEX and the ATC here as well. We also had to update our clinical procedures through this too, to help modify our protocols. We launched our educational app through the Google and Apple Play Store, just so it could be more accessible. A lot of our CHWs were giving telehealth accounts as well, just to make sure they're able to reach and keep that connection with the patients as they're going through the HCV care cascade. And then we developed a lot of COVID resources for our current patient population too, just so we're not just focusing on hepatitis C, but also aware of everything else going on around them too during the pandemic. Next slide. So some lesson learned: new protocols and implementation takes time. While telementoring is great, it usually does require time, commitment, and funding. CHWs are currently not reimbursed in the state of Texas, so we do require outside funding. It's not as sustainable. And then COVID-19 really implemented our clinics and pulled the focus away from HCV screening and management. So I think we're at a stage where we're trying to come back and really screen everyone as well. So next slide. These are some of our current ECHOs happening. I do want to highlight our HIV, our hepatitis C, and our Spanish language HIV ECHOs as well. Next slide. And next slide. And I know I went through this really quick. Just want to make sure we had enough time for everyone else. So if you have any questions, please feel free to connect with us as well. Thank you so much.
Thank you, Mr. Bobadilla. Last but not least, Dr. Andrew Seaman will discuss Oregon's use of the dried blood spot method as part of an ongoing microelimination project. Dr. Seaman is an assistant professor of medicine at Oregon Health and Science University, board in internal medicine and addiction medicine. He is an educator, addiction medicine, and hepatitis C researcher, and a healthcare for the homeless clinician at Central City Concerns Old Town Clinic. His research centers on the intersection of hepatitis C and the role of harm reduction in care for people who inject drugs. Thank you, Dr. Seaman.
Yeah, thank you all for having me. I will talk mostly about our new dried blood spot Hep C RNA validation. And why don't we move on? Next slide, please. These are my disclosures. I don't have a financial relationship with our partner lab. Some of this validation work was funded in part by the Gilead Focus Foundation. Next slide, please. So as many of you have all experienced in our Hep C elimination program, our screening rates dropped from about 400 tests per month to 160, and our case initiation, our treatment rates have gone down to about 15 out of 40 early on. We immediately offered initiation by telephone alone. We curbsided or delivered medications and increased our pharmacist-only treatment to about 90% of all visits. And although this work was already in progress prior to the pandemic, we increased the resources dedicated to validating our Hep C RNA test on dried blood spot. Next slide, please. So dried blood spot, if you're not familiar with it, it is used all over Europe and in Australia, et cetera. It's basically just fancy paper. It's called Watson paper. You poke your finger, you put a couple drops of blood on each of these little circles, make sure the blood soaks through, and you send it to a lab and it gets run. We did this validation with Central City Concern and a NIDA funded initiative through the Oregon Hope Grant under Dr. Todd Korthwis and our partner lab NTL. The benefits of dried blood spot is that it's approved for self-testing, meaning anyone can do this. So in the COVID era, you can do either self-testing completely or facilitated testing that's consistent with physical distancing. You only need capillary blood by finger stick. So there's no venipuncture. And this is useful for many reasons. One, for our folks who inject drugs, it is really difficult and traumatizing sometimes to access the volume of blood we need for Hep C treatment. And two, you can implement this anywhere. You can do this in the community and outreach settings. You can do this in opiate treatment programs and other places where standing phlebotomy services are really not feasible to implement. And then it's also very stable. And so if you dry it appropriately, these tests are stable for up to 30 days or longer. Next slide, please. The panel of tests you just saw, Hep C antibody, reflex to RNA, Hep B surface antigen, and HIV antigen antibody are, in addition to this Hep C core antibody, which we validated, unfortunately not able to do so on the dried blood spot card, but is on something very similar called the serum separator card. All of these are validated for, approved for self-testing. And in aggregate, we think those tests are sufficient to initiate most people on antiretroviral therapy, with the addition of some fibrosis assessment for some and maybe not for others. Next slide, please. So our initial validation results. So we collected 200 samples of DBS in parallel with serum labs. Of those, 50 were RNA positive. In that real world validation, we had 100% sensitivity for hepatitis C RNA and specificity as well. The lab also used reference samples to determine the lower limit of quantification and found that sensitivity to be 100%, down to about 600 international units. And then if you go down to the lower viral loads, it dropped down to just about 50%. Next slide, please. So we wanted to know what this actually meant in our system. So in the last 4 years of our program, we had 1,298 positive PCR tests. Of those, the vast majority were above that 600 international units. The majority of those were in that very low viral load cutoff. So we used these data as well as the validation data and looked at our baseline prevalence of 26% RNA positivity and our other screening test data, and predicted that had we used DBS, we would have had a negative predictive value of about 99.4% in our population. And I think the second question is really, how many of those people with a very low viral load would have gone on to spontaneously clear, which we don't have an answer to, but I think it's an important question. Next slide, please. So the other remaining question we had in sort of nervousness we had about implementing this test is the sensitivity of a Hep C antibody. So in the initial validation, the Hep C antibody on dried blood spot was 97.2% sensitive And again, that's comparing DBS to antibody to serum antibody in a reference lab. But when we asked them to share their raw data, in the reference lab values, the Hep C antibody signal to cutoff ratio was less than about 5.4 in all but one of those cases. And what we know from the literature is that people with these very low signal to cutoff ratios are very, very unlikely to have an active Hep C infection or a positive PCR. And so we think that actually sensitivity of this assay for people with chronic Hep C is actually going to be very, very good. The remaining tests on that panel were all 100% sensitive and specific. Next slide, please. So what will we do with this? So this is all our existing system that we're going to start to implement Hep C screening with DBS and the serum separator cards, as well as those other tests, into 2 opioid treatment program systems, 2 healthcare for the houseless clinics and medically supported withdrawal center, and then multiple street-based outreach sites, and then self-testing at 12 of our housing buildings, where we will basically give people a kit, provide a little bit of information on how to perform the test and collect some insurance data, and then have them submit those tests in. And then we'll complete whatever remaining workup we need, mostly just CBC and CBC, and then antibody testing for Hep B and Hep A ultimately, and hopefully complete most of this workup for those who need it in this way without venipuncture. Finally, we incentivize testing for all of our folks, so we are at least implementing that now, where there'll be $15 per test completed with results and $10 for referring others in to testing and treatment. And so the rationale for this is both we need to recognize the work that people who use drugs are doing to help end the hepatitis C epidemic. And also, we figure that if people were to refer others in their immediate social community that in for testing, that we might be more likely to diagnose cases and treat them in a cohort model, so they might be less likely to reinfect down the line and possibly work our way backwards through the hepatitis C epidemic and reverse the polls. Next slide, please. Big remaining questions. Can we get that much blood out of a finger? So this test will go live June 1st. We haven't been able to implement it yet. And this could be quite a lot of blood. And so there are potentially some challenges there. And then the question we have had is, how about the Hep C antibody? Is this going to be sensitive enough to use in our population at 26% prevalence or possibly higher in our opioid treatment programs? I think with the data I just shared, I think that actually this is going to be fine, and we intend to implement with Hep C antibody screening unless we have a confirmed prior case. And then what's our screening recommendations? I think we're going to, with these data, follow Q6 month or every 6 month or every year screening for people who are high risk, and then follow the recommendations otherwise. And then will payers reimburse? We think so. These lab tests will have the same CPT code as the normal Hep C antibody and RNA test. And so we really do think that they should be reimbursing for these tests. So with that, next slide, please. This is how you can reach out to the lab. Again, I don't have a financial relationship with them. If you want to get set up, talk to your local community Medicaid providers, talk to your local public health experts. I really think this could be a tool to get Hep C testing out to the most marginalized and highest risk populations for transmission and complications from Hep C. So with that, thank you. And I'm happy to take questions. I'll put my contact info in the chat. Thank you so much.
Thank you so much, Dr. Seaman. Unfortunately, we have run out of time for Q&A, but as discussed in the chat, we will be compiling the questions asked in the chat box, and we'll include them in a follow-up email, which you will receive soon, along with a copy of the slides, a link to the recording, and a link to the short evaluation survey, which has also been plopped in the chat box. On behalf of CDC and NASTAD, I'd like to thank all of you for being part of today's Testing Day webinar and discussion. Thank you again, and have a great afternoon.